Okay. First of all, thank you, Jennifer, Kelly, for your communication and for this offer to come up here. This is really an honor for me. It feels kind of coming home to me. Since 1954, my family's had a cottage over at Conneaut Lake. And I was driving down the road today past Home Depot, and I thought, I've never been here in a shirt and tie. I wish I just had my shorts on and I could go out on my old pontoon boat and fish today and go to Home Depot and get some stuff for this little cottage that's fallen down. But it's really nice to be here, because the other thing I was thinking, I was talking to my boss today, talking to people from hospice or who have experience from my world is kind of like preaching to the choir in a way. And what I try to do many times, I'm at this big high-tech hospital now, Allegheny General Hospital, where they're doing transplants and they're putting these heart pumps in. And what I'm trying to do most of the time is to teach them what you guys have been doing for years. And when you look at what they're doing, I know some of you, I've seen some of you like think, why are they doing that? Or why aren't they doing this? So this is really, I would really value your input throughout this too, because I don't like to just talk. I'm not just a talker. I talk a lot, but I would prefer to have your input, your experience, and not just of those of you who work in hospice. I understand there are some people from the community. Are the lay people from the community here? Can you raise your hand? Thank you. I was under the impression, actually, I was expecting mostly people from the community, and I thought that was really difficult, because it kind of goes along with what I want to talk to you about. When I'm talking to medical students and residents and other doctors, it's sort of this informative me telling them. And it's a little difficult when I'm talking to the community about these issues, because they're so personal, and there's not just this one-way passage of information. And it really is kind of a framework for what I do in work and what you all do, I'm sure. So let me just talk. I just want to talk a little bit about palliative medicine and what we do, because this is a continuing medical education experience. I have to give you some objectives. So my objectives are that some of you come to appreciate the concepts of shared decision making in medicine, and I'll go into that a little bit. To discuss the benefits of a palliative approach to medicine, something that many of you have been doing for a long time in hospice, and discuss the barriers and resolution to good medicine and symptom management. I always have to put this up. I have no financial disclosures, but I want to talk, this is more important to me. So this was a lady that came to me. I do 2 half-days a week right now in Allegheny General Hospital. I work in our cancer center in an outpatient clinic, and the oncologists refer patients to us. Typically people who have a lot of symptoms: pain, nausea, shortness of breath, family distress, emotional distress. And this lady, Mrs. D, she was a 71-year-old female who was really sharp. She was still running a business. She had her children worked in her business and were getting ready to take it over. She had grandchildren, and she was just tough. And she had recently been diagnosed with stage 4 or metastatic pancreatic cancer, which just by that in our medicine world, half of those people, a median life expectancy of 3 to 5 months. That means half of them have less than that and half of them have more than that. And there's no curative treatments right now. And what she said to me, it was referred by the oncologist because she was having abdominal pain from her cancer, and it was bad, and she was just miserable. And she said it was 9 out of 10 on a scale of, with 10 being the worst she could imagine. And she said, let me tell you, I don't want chemotherapy, I don't want radiation, and I don't want surgery. What do you think of that? And I was a little taken back, because I was ready to give her some information. And when I asked the residents that's where they go right away. How about any reactions to that? Does anybody have any thoughts about that? In some ways, I'll come to that. This was a rather easy case for me. What else would you want to know about this lady? Any questions you would ask her, or what do you think of that?
I would want to know what's important to her, or what's the most troubling thing to her.
You work in a hospice, don't you? You work in a hospice. Thank you. So what's important to her? Exactly. So here's what I said. And I was not sure what to say. And I said, I'm going to respect whatever decision you make. I'm just here to see if I can help you. And her response was, good. Now I want you to help me to teach my grandchildren how to die with dignity. So, any response to that? Or questions? Yeah, that's kind of where I was. I was like, wow, I could help you with your pain. I don't know if I would be so selfless. The residents and medical students, when I talk to them, they get very uncomfortable when they hear that. They say, I would tell her there's treatments available. There's good treatments available. Or I would tell her, don't give up. Or I would tell her there's hope. And this kind of comes into, I want to just ask you all for a couple of minutes, because this is a very personal, and if this is not too uncomfortable, I'd just like you to take a minute, maybe with your eyes closed, and picture your ideal death. How about anybody have any ideas? Any thoughts? In our world, in the Institute of Medicine, they have a little definition. And it's kind of what you guys talked about. One is free from avoidable death and suffering for patients, family, and caregivers in general accordance with patient wishes and family. And this is what we get. This part gets frustrating for me. we were just talking about why we did this, and somebody was a nursing student. I was going to be an intensive care doctor. Actually, when I was really young, I wanted to be a pediatrician because we had a really good pediatrician. His name was Dr. Good. And he was like a part of our family, and he would come to our house sometimes, and he would help us. My mother could call him any time of day. And I remember going to his office, and color forms were these little art things you used to make. And I remember going to his office one day, and mine was hanging on his wall from the last time. Now, I know he didn't leave it there. I know that today, but I didn't know it then. And those kinds of things were just really powerful to me, and I wanted to do that. I thought all my life I wanted to do that. And I got sick pretty young, and I wasn't able to do it. I ended up working in the clinical psychology field for a while, and when I was able to do this, I kept waiting, and I was in my second year of residency, and I kind of resigned to the fact that I was going to do intensive care medicine. And I was sort of locked into that. And I have to tell you, I was tired. And one month in my second year, I did a rotation of palliative medicine. And it was at Akron City Hospital, where they have an acute palliative care unit in the hospital, which is almost like a hospice unit for people who aren't quite ready for hospice. And so you could be receiving any kinds of curative therapies, chemotherapies, surgeries, anything. But if you had a lot of symptoms, either physical or emotional symptoms, family distress, they could bring you there. And it was an amazing place. Those of you who have been in an inpatient hospice unit, it kind of looked like that. It was carpeted. There were private rooms with showers for family members. There were roll-out beds for family members. There was always soup on during the day for family members. There were family rooms. And on the staff of that unit for 12 beds, we had physicians, nurse practitioners, nurses aide, a full-time chaplain, a half-time psychologist, a half-time pharmacist, a Reiki therapist, a massage therapist, physical therapist, and volunteers. And it was an amazing experience. And one day I was getting ready to do a family meeting, and I asked one of the attending physicians, I asked her if she would come in. I needed some feedback on a meeting for my evaluations, and I said, would you please let me do this meeting, and you come and you give me some feedback after? And when we were done, she said, it's obvious you found your calling. And I remember thinking, I don't want to do this. This isn't medicine. This isn't what I signed up for. I want to do intensive care medicine. And then for the next couple of weeks, I couldn't sleep. And I really was wrestling with it. And every time I'd see Dr. Sanger, she would say, so what are you going to do? Are you going to apply for the fellowship? And I would say, Dr. Sanger, I'm not going to do that. And then I had an old wise mentor, and he had me write some things. And he said, I want you to write all the pros and cons of ICU medicine for yourself and all the pros and cons of palliative medicine for yourself. And I was going to see him Friday, and he said, bring that to me. No, he said, email it to me, and we'll talk on Friday. And I emailed it to him, and I said, so Harmon, what'd you think about that? And he said, all I saw in ICU medicine was me, 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 me. And I knew, as soon as he said that, I realized that what I wanted to do ICU medicine was because it's manly medicine. It's rock star medicine. It's lucrative. And I thought people would think more highly of me if I did. I was terrified to tell the intensive care medicines I was going to do palliative medicine. I thought they were just, it just didn't feel right. But I can tell you, since I made that decision, I knew right when he said that I had to make that decision, that I don't know if I've ever woken up for work since then and thought, man, I don't want to go to work. I love it. And those of you who work in this field in all these ways, I love it. For me, it's what medicine should have been. And I think that's what I mean when we're trying to teach new physicians how to do what you guys have been doing. I can teach anybody to do certain aspects of what we call medical science. I tell the residents, like they want to, converting opiates to get for pain control. That part's pretty easy for me. It's pretty basic math. But to do what you guys to do and to try to involve patients and families in decisions about their health care makes it a lot more complicated for me. So I love now, everybody knows, I love when there's somebody like in 9 out of 10 pain and their family's in distress and they're fighting and the nurses are frustrated. I love that now. And those of you, some of you know what I mean, don't you? I love that. Not that they're in pain, but I know we can help them. And I know, I love going there, and I'll come back to you in a second. I get too excited about that. So just a little brief thing. In medical decision-making, many of you remember, and some of us still practice this paternalistic medicine. There's a book quoted at the bottom. I don't know if you can see it. If anybody's ever read that, Being Mortal, it's a fantastic book. I lived for a while in Athens, Ohio, and Atul Gandhi he's a surgeon at one of Boston's hospitals now. He's written a couple fantastic books about our healthcare system. This one is about what we do and what we're talking about. It's fantastic. Lots of great stories and experiences. And he's written a couple others, but they're good. And he talked about it in this way. So paternalistic. I say to that lady, you're going to take chemotherapy. Here's what the chemotherapy is, and this is what it's going to do, and you're going to take it. So this is it. Here's a red pill, you take the red pill. And that's kind of what my dad grew up with. And he talks about that still. And in his generation, people often, they would put their jacket and tie on to go to the doctor. And the doctor would sit with their white coat on and have their glasses down, and they would kind of look down and look at the things that nobody understood, right? We wrote in Latin so that lay public didn't know it, and we would use these big words. And still the residents, one of the hardest things I have is, like, they're using these words that nobody knows what they are. But it makes them feel good to use them. So we've kind of moved, and then what they've talked about now, there's this informative way of making decisions to give patients and families more input in that process. So we say maybe the blue pill does X, the red pill does Y, you decide. And this is kind of really common now because of the internet. I can't tell you how many people, and probably many of you providers are aware of this, and many of you who aren't providers know you do it, that there's a lot of information on the internet. And some of it very valuable information, some of it not so valuable. So a lot of it's helping people sort through that. And then this is what the big push in our field in medicine right now is, how do we move physicians and providers towards what's called shared decision making? And what you said, what's important to you? What are your goals? And my boss always says that goals have two parts. Physiology that I can give patients and families, and values that I have to get from them in order to make these decisions. So those of you who aren't providers, I'm glad you're here, because that's what we learn from you. So some of you told us about good experiences or what you would like for a good death. How about bad death? Would anybody be willing to share any experiences about a not so good death? I know this can be difficult sometimes. Yes, in the research and asking people, these are the kind of things that people talk about in a good death. And sometimes when we talk to the residents, I ask them, how many of these things do you attend to with patients? And I have to tell you, not many when I see. Because when I was in medical school, I can tell you, and there was always this stock answer, why do we use beta blockers in people with heart failure? And the answer was always, it improves survival. It improves survival. It improves survival. It was the reason we used all the medicines. Any of the medicines, any of the chemotherapies, almost all of the treatments that get approved, it's because they improve survival. And none of these really talk about that, do they? I think these are the things that we in medicine have ignored. So back to my lady, this was in my world, this was a relatively simple task. I know that 90%, and I think it's probably more than that, of patients with advanced cancer have pain that can be adequately treated with relatively simple measures. And there's really good data on that. So I can help her with her pain. Those of you who are providers, what I did really in the clinic, it's a chemotherapy place and they have nurses, so I just gave her some medicine there. I knew what she was taking. It's a very simple conversion to what I'm going to give her. And I said, if you can stick around, we can put a PICC line in you and give you a PCA to go home with. And that's, for those of you who don't know, that's called patient-controlled analgesia. So we started her on a steady infusion through an IV line that could stay in for a while, and she had a button to give herself another dose every 15 minutes if she needed. That's pretty simple. And our home care nurses can go out and see her, and if she's pushing this button once an hour, then we know how much to increase it. That's pretty simple. And as far as her, really what she wanted to do, I believe this was probably in early February, and her real wish was to have an Easter dinner with her children and grandchildren, but it was going to be early in February. And she said, I'm going to do it in 2 weeks. I'm planning it, and we're going to do that. And she wanted to be comfortable for that. So that part's easy. And if you look at these diseases, that sort of trajectory is, 100 years ago, people were dying rather sudden deaths. They were dying of infections, primarily infections and accidents. Most cancers 20 years ago looked like that. Now, there are a lot of cancers where people are, and I always want to be careful because sometimes I get a jaded view. When I was a fellow, always had to go to outpatient oncology clinic because we saw that there were people benefiting from chemotherapy, radiation, and surgery. I won't say that they don't. Please don't ever let me sound like I'm discouraging those kinds of things. I have patients in the clinic that I see because our oncologists have allowed me, and they've been 30-year breast cancer survivors, and they're doing well. But that's not really what happened. And the other night I was talking to my uncle on the phone, and the problem with this is that what that leads to is what we have in medicine, this dichotomy. So I don't know if you can read that, it's a little blurry, but the green side is where we provide curative or life-prolonging treatments. That little blue side is where we provide palliative medicine. And that's been the dichotomy in medicine for a long time now. I still hear on the unit sometimes, oh, he's not palliative. Why are you seeing him? One of the cardiac interventionalists just the other day, I was going to this meeting they had. Oh, I hate those meetings they have because I don't fit in there. And they were like, we don't need no palliative care here. And of course you don't, right? And even the medicines, in my world, I know that we use a lot of opiates. Morphine, Dilaudid, hydromorphone, oxycodone is the one you hear all over the news today. And physicians are terrified of it. Providers are terrified of them. And I ordered morphine for someone, and they canceled it. The attending physician canceled it and said, I'm not going to give him morphine. He's not palliative. So this dichotomy was okay 100 years ago, 50 years ago. But I was talking to my uncle the other day. He's in North Carolina. And my Aunt Dolores is 85, been married 63, lives with her husband. Thank God my cousin Rick retired from his job in Houston, Texas, built a home in North Carolina and moved his parents upstairs. She's had multiple strokes and her dementia's getting worse. She has moderate to severe dementia now with memory impairment, frequent falls. She just fell and hurt her ankle again the other day. And she has dysphagia, which is a big thing in our world, trouble swallowing safely. For many reasons, patients have trouble swallowing safely, and they lose that mechanism to protect their airway, so they aspirate. And that's the big term we use for when things are going down the wrong pipe, is what I grew up with. And sometimes patients are aware of that, sometimes they're not. So historically, there's still a big debate in the hospital. Somebody with advanced dementia, if you go to many nursing homes, there are a lot of people with what's called a PEG tube. And it's a percutaneous esophageal gastroduodenal tube. And it's a surgical tube that goes in because if they're not swallowing safely and they're going to get pneumonia, let's feed them this way, right? And there are very good reasons to use them, and they help a lot of people. But I think, like a lot of our technology, we have these people, and if you look at the large studies, people with advanced dementia, it doesn't improve the length of their life. It doesn't reduce the risk of their aspirating, because if you think, it's very common sense when somebody told me, if I'm aspirating, it's not the bacteria on my food that's causing the problem, it's every time I swallow in my saliva. And then they get infections, and then they're delirious, and they're pulling at these things. And my uncle's starting to go through these stuff and having these decisions, facing these decisions, and he said a couple of things to me that struck me. He said, what he said was, one moment she's lucid, one moment she's Looney Tunes. And I didn't want to put that because it sounded kind of cruel, but that's what he said, and he said it's so frustrating. He said if it were where she was confused all the time, this would be very easy for me, or much more simple for me, is what he said. I could put her in a home. He said, but it's not, it's this. And he said, I feel, even thinking these things, I feel guilty. I'm stressed, I'm afraid. And he has the means right now, thank God to his son that took him in. So those things are the more difficult. And she's not alone, because people don't die like that anymore in the United States. Very rarely. 7 out of 10 Americans die from chronic diseases. More than 90 million Americans, that's about 1 in 4, live with at least one chronic disease. So they're more like that red line. When I came to Allegheny General, half of my time was to be paid for by the cardiovascular division, because in their guidelines, they're finding that people with heart failure have a lot more symptoms than they ever imagined. And they have an outpatient clinic and they have a lot of symptoms. So they asked me to come in. They brought me in. Really, it's been very frustrating, I have to tell you, because this is an advanced center, right? They're doing pumps. They're doing these pumps where they open up your chest, they put in a pump to take the place of your left ventricle, and then you have a drive line, and you have a battery pack, and you have a motor there. And it takes the place of your heart. And people are doing better with them, but there's a lot of risk to them. Initially, these things were made as what was called bridge to transplant. So if I need a transplant and I'm on the list and I can't, they put this in and they try to keep me going. But what they found was there's a lot of risk factors. People were having strokes, people were having blood clots, people were having pain, people were having infections. Now they've gotten better. Those pumps have gotten a lot better. So much better that now we do them, they're called destination therapy. So people survive 5 to 10 years with some of the new ones. Dialysis, I just met with all of our kidney doctors. Dialysis was the same way. Dialysis was made for people that had a short-term kidney injury, and we're going to get either over that or maybe get transplants. And then Medicare made it available, and now we have people doing well. Again, I'm not criticizing. I would never. People do very well on dialysis, and it's a wonderful life-saving thing for many people. But we're finding now that there are certain groups of our population that we give dialysis, and it doesn't extend their life at all, and it worsens their quality of life. Somebody was talking to me about quality of life before. So these decisions have gotten much more complicated than this here. And what do we do? So the heart failure people, I go to the heart failure, and there was actually a study in 2009 where they looked at people in an advanced heart failure clinic like ours, and these people were getting a lot of attention. Nurses, social workers, physicians, dietitians, home care visits, chaplains. There's a lot of stuff going on. And this study in 2009 showed that people with advanced heart failure, stage 3 even, and 4, New York Heart Association, have symptoms that are equal to people with advanced cancer. So more than half of those people in a big clinic have at least moderate pain, shortness of breath, nausea, depression, and fatigue. And if you tell the cardiologist, they say, well, they just need more Lasix, or they need more beta blockers. But that's not the case. This is the most advanced. And they said, not in our clinic. This wouldn't take place in our clinic. So one of our residents did a study, and she found the identical results. Because most of our therapies don't consider pain, nausea, shortness of breath, depression, fatigue, anxiety, emotional distress, family distress. They consider survival. And if they improve survival, let's do them. So there have been studies about what people with serious illness want, and it's very similar to what people want out of a good death. I won't bore you to read them, but they're the very same things. And none of those, again, are what our residents are familiar to deal with. And I agree. And part of that is being 20 years old, 22 years old, most of the residents. The other part is that we don't train these communication skills that we teach residents. They're very teachable. And I'll come back to that in a little bit. We just don't listen very well. We're good at talking, and sometimes we talk. We give information, and I'm looking, and this resident's going on and on and on, and I can see the patient's eyes rolling back, kind of glazed over. My mother died in a long-term care facility, unresponsive for 6 weeks, and my dad's a retired telephone worker, and I remember him coming out of these meetings and thinking, he'd say, Dave, I don't know what they said. I have no idea what they're telling me. And I was a third-year medical student at the time, and I didn't even know what they were saying half the time. And so one of the things, actually, you mentioned, one of the things I do with the residents, and it's very uncomfortable for them. So they have sort of, in the medical world, they have sort of, it's called a history and physical, and it's just a format of things. Ours is expanded. It has, history of present illness, past medical history, family history, social history. And the social history in the medical world historically has been, do they smoke? Do they drink alcohol? Do they use illicit drugs? Right? In ours, we have it expanded. Family support, coping, mental health history, religious and spirituality, and advanced care planning. That's the hardest thing for them. So I tell them, okay, here's what I want. When we go in to see this patient and family, I don't want you to mention any medical issues or ask any medical questions for 5 minutes. And they're paralyzed. But once they get to do it, talk, idle chit-chat. I want non-medical chit-chat. I want you to know their husband's sitting there. How many years have they been married? They're married 60 years. That's important. I want to ask, who are the photographs you have on your table? Those are going to be important when you're helping them make these decisions. Who made that blanket you have on you? Those are important things that we don't ask, and we need to be asking. And I know you hospice people were like going, duh, no kidding. This is what we do. What is the best thing you can hope for, and what is the thing you fear most? I'm saying that because I want to make sure that principles that guide the practice of medicine in the United States, and one of them is autonomy. So patients have the right to make decisions based on their own behalf. And another one is informed consent. So I can't tell you how many times I just happened to be in the hospital Saturday, and these nurses were arguing with a resident over whether they need to get consent from a patient's family to put a PICC line in this person. And they said, what do you think? And I said, well, the paper of getting something signed is sort of the end, right? What's the principle? Do you think this patient, and if they can't make the decision, do you think their family has a right to know the risks and benefits? And they said, well, we do IVs all the time and we don't get sent. But that's not an IV. This is an IV that goes into their main vein right next to their heart. So sometimes we get caught up, and I understand. I have to tell, one of the oncologists said to me, Dave, I can tell you one of the reasons I don't consult you is because I think I could do what you do. And I said, you probably can. The data doesn't really support that you do very well, but I said the thing I can probably give you is time. Because I get an hour, for my clinic patients, I get an hour per patient. I can take that kind of time that they can't take. I'm looking, I just saw that I'm kind of going on time here, so I'm going to speed up a little bit. And I want to just talk, this is actually perfect. So this is something that you see, and it's something you alluded to, and it's something that is very frustrating. So there are certain things in medicine that, and I don't know why, I'd like to see a research. There are certain things in medicine that people think they should know how to do without having to learn how to do them. Talking to patients is one of them. No resident comes to me and say, I'm uncomfortable talking to patients. Can you help me with this? Maybe some do now. Treating pain is another one. I can't tell you how many family conversations I have where somebody will, because I'm a doctor, somebody will say, hey Dave, what do you think I should do about this? And my dad or my sister will say, well, just do this. I tried this. Everybody just thinks they know. So residents do it. So some people come in the hospital, they have 9 out of 10, and the resident will order a Percocet every 6 hours. And all the science goes out the window. Now, when I look at it, I think, why'd you pick a Percocet? Why'd you pick one? Where'd you pick that dose from? Why'd you pick 6 hours? Nobody gets 6 hours from a Percocet tablet. And then they walk away. Then the patient's left asking the nurse for pain medicine, and the nurse has to say, you can't have it for another couple hours. And the nurses are often afraid, because of our paternalistic doctors, the nurses are afraid to call the doctor and say, hey, this guy's in pain. Especially in the middle of the night. God forbid you had to call somebody. So we don't do well with pain. And it's not just cancer. Look at those numbers at the bottom. 75% of pain is inadequately controlled. And I don't mean just using morphine. There's a lot of things we can use to treat pain. And on our palliative care unit, man, we had massage therapists, we had social workers, we had chaplains. I'll tell a story. This is kind of, I don't know why this came to my mind, but I almost feel hokey. This is where my manly kind of medicine, when I tell these kind of stories, I feel hokey. So I was in fellowship, and there was a doctor up there. It was a rural hospital, and Dr. Dieter, somebody told me I had to go spend time with him, because he was involved in a program called The Sacred Art of Living and Dying. And I said, to one of the attending physicians, I said, I understand that you guys do all this grief stuff, but I sort of get it up here, but part of me's thinking, is it really worth all this time we spend on it, And she said, oh, you need to go spend a month with Dr. Dieter. So I go see this patient, and she's 88 years old. She's got pretty newly diagnosed metastatic stage 4 small cell lung cancer. And she comes into the hospital for intractable pain. And it's like 8 or 9 out of 10. And they gave the medicine list, and she was on about an equivalent of about 900 milligrams of oral morphine a day, which is it's a good amount. but I didn't know what to do. So Dr. Dieter and he starts helping me. We started off slow, and we kind of go up. And the next day, 8 out of 10. And she's getting a lot of pain medicine. And 2 days later, 8 out of 10. And he said to me, he said, okay, so what are you going to do? And I said, well, I'll change her to another opiate. And he said, here's what I want you to do. He said, I want you to go and sit at her bedside and tell her what you see. And I didn't know what to do. And I went in and I said, Mrs. P, I can't help to think that every time I talk to you, you're troubled. And she started this conversation, started this talk. She talked for 45 minutes, and she had been originally from West Virginia, and she talked real slow. And then she would close her eyes, and I'd start to get up, and then she'd start talking again. And she told me this story about how when she was 5 years old, her dad gave her this little trinket with 2 lovebirds on it. And then one day he came home from work, and he took it from her, and he snapped the necks off. And she told me this and she was crying. She's 88 years old. And then she told me that her kids were taking her medicines. And then at one time in a hospital, they thought she was dead, and her one daughter came in and took her jewelry off of her. And I just sat there for 45 minutes, and I told Dr. Dieter, I don't know what to do with all this. And the next day I come in, and this is the hokey part, and I said, Mrs. P, how are you doing? Tell me about your pain. Can you give me and she said, it's about a 3 out of 10. And that's the part that feels hokey about this to me. And those of you in hospice, you know, the Dame Cicely Saunders that started the concept of hospice came up with a concept called total pain, where we consider patients' families, their emotional, their spiritual, their existential factors that could contribute to their pain. Now we've kind of spruced it up, and in the National Cancer Coalition Network's guidelines, they have a whole section on distress. They call it distress. And it's exactly what you guys have been talking about in hospice for years. And what we're trying to get back to in medicine is to take those things into account. So I just want to talk about one study. I have about 5 minutes here. So why don't we talk about it? So because of this, in our cancer clinic, 70% of patients want their cardiologist to talk to them about the end of their life planning. About 20% do have that conversation. Part of it is this: when do you talk? You know, the cardiologist said, I don't want to bring it up because I don't want to take away their hope. And if you look at the data, it doesn't support that those conversations take away hope. People want to have them. Most people want to have them. The other part is we can't predict. We don't predict. How many of you in hospice have had people come to you and they're obviously dying and nobody has told them or their family that they're dying? So our doctors, this was a study where 350 physicians, and patients who were enrolling in hospitals, so they have by definition terminal diagnosis, a life expectancy of 6 months or less, and they asked the doctors to predict how much longer they live. The doctors overestimated it by 5 times. And one of the catches was the better the doctors knew them, the worse they were. So medical students did better than the patient's primary care physician. So I'll let you sort that one out. And if they do talk about it, here's what our residents do. They talk about 5 to 6 minutes, they talk for 2/3 of the time, and they don't consider patients' values or preferences. Good data on that. So the result, patients often get treatments and procedures they would decline if they had the opportunity. Not that they're bad things. The big one in the hospital right now is cardiopulmonary resuscitation. CPR, chest compressions, intubation, which again was made primarily for 40-year-old healthy males. And people survive it and people do well. So I'm not saying do it or don't do it. But I think we have to give people the information. You know, there was a study in the New England Journal of Medicine that said 83% of patients over 70 believe they have a 50% chance or better of surviving CPR. In general, In the hospital, if you have a cardiac arrest in the hospital, your chances of surviving without significant brain damage are 15%. And that includes people who it happens on a table where they have things to shock them right there. And over 70, it's about 5%. And then if you add on where my mother was with diabetes, chronic kidney disease, stroke, all these other things, her chance were negligible and the chance of us causing harm. So we need to give them this information.
Part of that problem is television.
It is. If you look on television,
Television, they have a CPR, they resuscitate them, and 10 minutes later they're eating bagels.
67% of the episodes on television, they survive with good neurologic. So the other problem is that decision makers suffer. So this I just want to share. This is kind of what we're proposing in our world, is that we use this model here. Rather than this dichotomous model, my best example was at Akron Children's Hospital. When kids are born with really severe congenital heart problems, they get a palliative care consult at birth. And very early on, the palliative care team's role might be very superficial, just purely supportive. But as these kids develop more symptoms and have more distress and more problems, they have this relationship by which to carry on these conversations and treatment. I'm going to skip a couple of slides because I have to finish up here. So last thing, some people say, well, isn't this just good medicine? Lay people say this, no, isn't that what you're supposed to do? We thought that's what you guys were doing, talking to people. I just want to show you one study. So we know that palliative medicine improves quality of life, that it improves family quality of life and experience, and that it's cost effective. This was a study that's kind of thrown our whole cancer world on their heads, because they would say it doesn't improve survival. This study, 2010, New England Journal of Medicine, they took 150 people who had just been diagnosed with non-small cell lung cancer, stage 4, and they randomly assigned, it was a really good study, randomly assigned them to standard oncology care or standard oncology care plus the addition of a palliative care consult. And that was a team of people, physician, nurses, social workers, chaplains, other people that could help them. The people that had that consult, they had a better quality of life as expected. They had fewer symptoms of depression. And this was the one that really got everybody now, is they lived 30% longer despite less aggressive treatment. So now in my world, everybody that comes onto our cancer unit gets a palliative care consult starting next month. Because we can try to educate them, but education goes about this far. My boss says you just got to push it on them. Like when we told people smoking's bad for you, it had some effect, but now we start making them show up with IDs. Now we start raising the taxes. So I can see that, Jennifer, I'm just about finished here. I'm going to sum up here. The last thing I just want to add is that it doesn't take specialist palliative medicine people. That people are talking about developing programs. The thing I would encourage is get a team. Have a team. You guys do it best in hospice. Have a team of physicians, nurses, chaplains, social workers, volunteers. So everybody, if we can take on this palliative care approach and provide symptom treatment throughout the course of any serious illness, we can reduce the risk of patient distress. We can improve family outcomes. It's cost effective. It keeps people out of the hospital. And ultimately, I think we probably improve the course of some of our illnesses. I'm an internist, so I don't consult the endocrinologist every time somebody has diabetes. And I don't expect them to ask me every time. But I do expect them to sort of practice the principles we know in medicine to providing this kind of care. So I think I'm finished here. Am I finished, Jennifer?
Yeah.
Thank you.
Yeah.
I just want to add, I have 2 packets. For those of you, for lay people, there's a packet out there. There's a lot of good information on the internet about sharing these things with your family, about sharing these things with your doctor, about helping get them involved in your decisions about your health care. And for professionals, there's a handout of 4 phenomenal, there's websites about these things, and there's good educational programs available to you. So thank you all again, and congratulations to the hospice for the work you do.